Well, good evening, everyone. It is my pleasure to welcome you to the 4th Annual Pink and Pampered at Home, presented by Touro, an evening where we celebrate all things women. As in the previous years, we have an exciting night ahead with at-home pampering, shopping for a cause, and valuable information on women's health. We'd like to give a special thanks to the Touro Infirmary Foundation and the Hebe Family Fund for making this event possible. If you haven't done so already, visit our virtual photo booth using the QR code and help us share the pink. Take a photo of your at-home pampering and use our Pampered in Pink special photo frame. Our virtual photo booth will be available all month long. Last year's Bra Dazzling for Breast Cancer was so successful, we want to bring it back for our virtual event this year. Various Touro departments have decorated bras that are being auctioned off to support the Supportive Cancer Program at Touro. The link to our online auction was included in your email confirmation from yesterday, and we are also sharing the link in our Q&A section here. Let the bra dazzling begin. Now, please join me in welcoming our panel of expert physicians from Touro. This team of medical experts will share some important health information with you, and then we'll open it up for questions from the viewers. Please don't be shy in asking questions. We want this to be interactive and an informative discussion. Now, please join me in welcoming Dr. Kristin Green, Obstetrician and Gynecologist.
Hello.
Hi. Dr. John Colfry, Breast Surgical Oncologist.
Hey, guys.
Dr. Stephanie Losq-Sarkar, Family Medical Physician.
Hi, how are you?
Dr. Melanie Sheen, Hematologist Oncologist.
Hey.
And Dr. Elly Zakris, Radiation Oncologist.
Hi.
So nice to meet all of you.
Pleasure.
So we will begin with some panel questions. And first question is for Dr. Zakris. Tonight's panel is all about breast health. One of the most important modalities to determine breast health is through screening mammograms. What are the current recommendations on screening guidelines, and when should women start getting mammograms?
So can everyone hear me?
Yes.
Am I on? So there's a lot of different screening guidelines, and I think that's where there can be confusion. I like to follow the American Society of Breast Surgeons, which is also in agreement with the National Cancer Institute and the NCCN, or National Comprehensive Cancer Network. And what they all agree on is that women ages 25 to 30 should have a formal risk assessment performed. And if you're average risk, then you should perform annual mammograms starting at age 40. If you're high risk, and what that means is that your lifetime risk of getting breast cancer is over 20%, then we start annual screening at 35 or even younger, and we do additional screening services. Besides mammography, we do ultrasound and MRI. So other American Cancer Society is recommending age 45 to start screening, and the U.S. Preventative Services Task Force recommends starting screening mammograms at 50. But we at Touro follow the guidelines starting at age 40.
All right. The next question is about surgical options and reconstruction. So this question is directed to you, Dr. Colfry. After a patient is diagnosed with breast cancer, you're often one of the first physicians the patient will meet with to discuss their treatment. How does that conversation typically go? What decisions are made in that initial visit?
Yeah, I think, the first time that we see the patient, they are very scared, and sometimes the fear can be a bit overwhelming. And so we try to ask people when we first see them to keep an open mind as much as possible. It's also good to bring a loved one with them as sort of a second set of ears. But one of the biggest decisions, that women have to make is, can we preserve the natural breast, or does the natural breast need to be removed and reconstructed? And, you know, a lot of times patients come in and the first thing they say is the fear is there and they want all the breast tissue removed. I want a double mastectomy. I don't want to talk about anything else. What I want, this is what I'm getting. And I understand that completely. But, you know, I think it's our job to sort of sit down, educate people. That's not always what needs to be done every single time. And so it's hard. The fear is there. We see it every day where it comes in and it really overwhelms people. And we try to educate people, try to have them keep an open mind as to other options. But that's the biggest decision we help people make is, can we preserve the natural breast and keep it still looking like a natural breast? Or do we, you know, is there too much disease and does the whole breast need to be removed? And if so, there are options. You know, with time, it's gotten better than it used to be. It used to be very disfiguring. You know, nowadays we make smaller incisions that we try to hide as best as we can. And we can keep the outer shell of the breast for women that need to have a mastectomy. They keep all the skin. A lot of times they can keep the nipple even. And a plastic surgeon comes in at the same time and rebuilds the breast, either with like a breast implant, or sometimes they can use their natural tissue, their own warm living tissue, to build a new breast that looks very, very similar to their original breast tissue.
Okay. Well, that leads into my next question. Many
There's a question in the chat. Does the timing ever change for mammograms for low-risk women over 60? More or less testing? I mean, I'll answer it, but then Dr. Colfry, I mean, I think that for a low-risk woman at 60, I would continue yearly mammograms. I don't agree with that every second or third year. Yearly mammograms, monthly self-breast exams, and yearly exams by a doctor for an average risk woman that's 60. Dr. Colfry, do you agree with that, or?
Yeah, I agree with that too. I think, you know, the water kind of got muddied a little bit over the last couple of years with certain societies recommending different things. Sometimes, and again, maybe Dr. Stephanie can address this too with maybe her society's guidelines, but you know, we tend to follow American College of Surgeons, American Society of Breast Surgery, American College of Radiology. You know, we see every day where people, and again, I'm not trying to incite fear or anything like that, but we definitely see every day where people have skipped 2 or 3 years and now they come in with something that if they had gotten the yearly mammogram, it would have been a lot easier to fix. It would have been just a lumpectomy, and now maybe things are different. Maybe it's in the lymph nodes. So I agree with Dr. Zakris. I don't agree with that. We tell people, if you're healthy with a reasonable life expectancy, you get a mammogram every year, period.
And if there's other questions, you can put them in chat or in the question and answer.
Okay. All right. So the other question that I had for Dr. Colfry was, many campaigns in breast cancer and breast health today use the slogan "Save the nipple." What does that mean in terms of breast surgery? Is it true that we can typically save the nipple and still cure the patient from cancer?
Right. Yeah, this is one of the hot topics. I mean, again, for women either that have a lumpectomy or a mastectomy, the question is always, can we keep the natural skin? Can we keep the nipple? That used to not be something that was offered. You know, nowadays we're doing nipple preserving procedures on more and more people. And I guess it really involves mastectomies. And typically it used to be, the teaching was, if you had size A or B breasts, that those were the only patients that could preserve their nipple. That is not true. I mean, we do nipple sparing mastectomy on people that are double D breast. And so, you know, our techniques have changed, our skills have changed over time. So we've just gotten better at keeping the nipple and all the skin. The biggest thing is that you have to make sure that the disease is nowhere near the nipple, right? So that's the biggest thing. You have to have accurate imaging, typically including an MRI, that shows that the cancer is near the nipple. If there's if it's anywhere in the proximity of the nipple, or if there's any concern that it involves the nipple on either physical exam or, more importantly, the imaging, then it's not safe to keep the nipple. But that is only happens probably, I don't know, it seems like in our practice maybe 10 to 15, 20% of the time that it's too close to the nipple. So most of the people that we operate on that have mastectomies, for the most part, have their nipples preserved.
Okay.
Okay, another question from the audience. At what age should a teenage girl begin self-breast exams?
Yeah, I mean, my opinion is 18. I don't know if anybody else.
I would agree with that. I mean, there's no definite answer here, but I used to give talks to the graduating seniors in high school just about breast health and wellness, and that's what I recommended too. And we've certainly seen women, girls at age 18 have breast cancer, although it's very rare.
Yeah, and I think that also making young women aware of like what their breasts feel like, and also kind of make it less scary to like examine yourself and then do those self breast exams, I think is also important to like empower young women, so that they kind of get a sense of what their breasts feel like, and that's not just as scary as as it might be if they're not like taught about it at an earlier age. So I think that's also what's nice about it too, is to kind of make it a little bit more, kind of more normalize it a little bit more, so that young women feel empowered and safe to do those kinds of things, to do that.
One of the tips that I actually give my patients, just so they could feel comfortable with it, is just, you don't have to be an expert to check your breast. Your job is to just realize what your normal breast tissue feels like. That way, you're the one who's checking your breast at home all the time. And if you feel anything abnormal, then that's when you call in and let us know, hey, this wasn't here 2 months ago. Think I need to come in and be seen. And we try to get them in as soon as possible so we can evaluate them.
And people may be a little bit scared off of doing self-breast exams because the research out there is a little bit murky on self-breast exams. We know that self-breast exams in clinical trials haven't really shown to decrease death from breast cancer, but as everyone has said, it's all about breast awareness. You're gonna have trouble knowing if something's abnormal if you don't know what your normal feels like. And everyone has different breasts. So you've really got to know what your breasts feel like so that you can identify if there's something abnormal.
And I'm going to ask a question. So is there a better time to check your breast, or what about around your cycle? Does that matter if you're doing a breast exam around that time? When your hormones or your breast may be a little bit enlarged, or the breast changes. So is there an optimal time of the month to check your breasts?
Usually it's pretty much the week after your cycle. I mean, that's when you're under the least amount of hormonal influence with your breast tissue. So I usually tell them the week after your cycle is done, just go ahead and take a feel just so you can know what everything feels like.
And Dr. Colfry, this is the last question. Surgical options that are available for women battling breast cancer, and I heard you mention the lumpectomy and then also the mastectomy. So if you could explain those and then the options.
Right, yeah, kind of as I said earlier, I think it depends on, the biggest question I answer every day is, are we able to preserve the natural breast, which means doing a lumpectomy, removing the problem area with a healthy rim of tissue around it, or is the disease enough that they need to have all the breast tissue removed? So that's the biggest thing that option that we have counsel people through on a daily basis. And it's a big decision. I mean, these are decisions that this is going to be forever, and so it's not something I take lightly. It's not a discussion that should be taken lightly, and we encourage people to go home, talk to your family, don't make any quick decisions, right? I mean, that's one of the things with breast cancer too. we see a lot where, people feel like I got to make a decision like today, and actually the right answer is always slow down, make sure we have everything laid out, make sure we know the true extent of the disease, make sure we know what the full battle plan is going to be, so that you go into this knowing, care from my end to Dr. Sheen's end to Dr. Zakris end, all across the board. Other things I guess to talk about would be the reconstruction techniques. And again, I do the removal of the cancer, but we work with a bunch of great plastic surgeons. And one of the things that's done in New Orleans is the most, honestly, is, using your own tissue to reconstruct the breast. And really the reason is that that whole technique was worked out here in New Orleans before anywhere else. And so there are lots of great plastic surgeons that are excellent at doing it here. As I said earlier, when you can use your own natural tissue, it's your tissue. And so it's built to last. It looks more natural and it'll last you longer typically than artificial reconstruction with an implant.
Okay. So there's a question. Someone's asking, since I had triple negative breast cancer, should my daughters be more concerned about breast cancer?
I mean, to be honest, it really doesn't matter what kind of breast cancer you had in terms of like your familial risk. The things that really matter are age at diagnosis and family history. So like if you have triple negative breast cancer and you're 75, that's very different from a risk factor of someone who had triple negative breast cancer at 35. And there's a couple different calculators out there that we use to calculate familial risk. And so that can be done. A lot of our, I know our imaging team, Dr. Rupley and Dr. Oncol, will calculate your risk pretty much anytime you go to Touro for a mammogram. And they'll be able to tell you, are you at high risk? They can even look at, kind of plug in some of those variables for your children and see, are your children at high risk? So the thing is that specific type of breast cancer isn't as important as age and family history.
I mean, in general, if you have a triple negative breast cancer and you're under 50, we would offer you genetic testing. And so like what Dr. Sheen said, the age at diagnosis is really important. And I think with triple negative breast cancer overall, there's like an 8 to 15% chance, depending on your age, of having a BRCA1 or 2 mutation. So we'll talk more about that this hour. But
okay, another question. My mother had breast cancer and takes letrozole. She was told she must stop at 85. What is the reason? And does that increase her risk for more breast cancer?
So I'm not entirely certain why she was told that she would need to stop letrozole at 85. There's no real cutoff in terms of that. I have patients in their 90s on these medications. It may more have to do with how long she's been on it. The standard for estrogen blocking medications for breast cancer has more to is going to be 5 years to 10 years, depending on size of tumor, number of lymph nodes that were involved. Was there a high risk score on genomic testing or kind of that fingerprint testing for the cancer? So there are a lot of other there are a lot of other factors in play. I'm not sure. I've never heard of a absolute age cutoff for any of these medications. So I'm not sure why 85 was chosen unless she started at age 80 or started at age 75, in which case it just so happens that it would be 85 for her. And then does that increase her risk for more breast cancer starting the stopping medication at 85? Again, it has to do with how long she's been on it. Because if she's on it for 5 years and 5 years is appropriate for her case, then stopping it does not increase her risk for further breast cancer. In fact, being on it for that amount of time actually lowers her risk of future breast cancers.
Thank you. We do have a follow-up comment to the question about the triple negative breast cancer. She's saying that she's 38 and tested negative for all 27 genes. So that was a question about, should her daughters be more concerned about?
The age is very concerning. So.
Yeah, I think it's important to know that even though like Melanie said, I think that's a great point. Age is concerning, and even though the genetic test is okay, that is reassuring. But you know, there's still number one, genes we don't know about, and number two, you know, some of it has to do with environmental triggers that cause this, and so that's why one of the reasons we think family history is so important is that you grow up in the same environment. And so, you know, I think if it was an environmental trigger and not a genetic trigger, your family's been around you, your kids have been around you, so their risk is just a little higher. And so it means that they have to take it very seriously. And when they hit, you know, age probably 30, you told me you're 38, so probably 5 years before that, age 33, they need to reach out to their caregiver and start some sort of screening. Maybe it's an ultrasound every year, maybe it's a physical exam every year, but probably something at age 33. It's a good sign that the genetic test was negative, but they still have to take it seriously for the rest of their life.
And those recommendations are going to be regardless of the triple negative, estrogen positive, HER2 positive. Yeah.
There's another question. Is there an optimal time for women who no longer have cycles to do their monthly exams? I don't know if Kristen or Stephanie, you want to take that?
So women who no longer have their cycles, whether or not they've had a hysterectomy or not, should still come in to do annual exams, annual pelvic exams, as well as continue to do monthly breast exams. Again, the key is to realize what your normal breast tissue feels like. So definitely don't stop. Don't stop. Just keep doing it.
Okay, Dr. Zakris, Dr. Colfry mentioned earlier the idea of breast conservation, which often requires radiation afterwards. What can patients expect from radiation, in particular during their treatment at Touro?
So I'll give a little plug for Touro, but basically most women, although not all, who undergo partial mastectomy will recommend following that with radiation. Radiation's a daily treatment, 5 days a week. We give it for 3 to 6 weeks, depending, and it usually takes about 15 minutes. I view Touro, even though it's a community hospital, as a center of excellence. So I'm the director there. I trained at a very big center at Harvard's Dana-Farber Cancer Institute, and we've brought all of their cutting edge cancer treatment to Touro. We do meticulous treatment planning that's individualized, so normal organs like your heart and lung get minimal exposure to radiation. We treat everyone like their family with very compassionate care in terms of the delivery of radiation and as well as the treatment of side effects. We touch on emotional, social, physical factors. We continually update everything that we, our knowledge base and our technology. And so we hope that we make a very frightening situation less so in our department. We also work really, really closely with the breast surgeons and the breast medical oncologists, and the care is very, very individualized.
And I'll give Dr. Zakris a plug. If any of you have ever visited with her or her team, they do something special down there. They've got a special group of people, she and Dr. Harmon, and you guys do a fantastic job.
Thank you.
I agree, 100%. All the patients love them.
Thank you.
All right, so the next question is for Dr. Sheen. Oftentimes when women hear breast cancer, they automatically think chemotherapy. In regard to breast cancer, is chemotherapy always required?
No, so we have come leaps and bounds, really even the last decade in treating breast cancer, where a lot of women don't actually need chemotherapy. There's a big push in the world of medical oncology, breast medical oncology, for what we call de-escalation of therapy. And so what that means is, where 10 years ago, someone may have gotten a lot of really strong doses of chemotherapy, now you may not even need chemotherapy. You may only need one chemotherapy and one targeted agent. So it's really moving away from chemotherapy and giving patients who have breast cancer only what they need. And so I referenced it a little earlier with the patient whose mother is 85 on letrozole, but we have these tests called genomic assays. And I like to describe them as like fingerprints for the cancer. So what they do is these tests look at a sequence of genes that the cancer has, not that the patient has, but the cancer specifically has developed. And these tests give us a calculated risk of recurrence. What's the chance that this breast cancer is going to come back somewhere else in the body, in the lungs or in the liver, in the bone, where we can no longer cure it? And if those patients' cancers come back as low risk, that means that they don't need chemotherapy. So a lot of times we'll send these tests on patients who had 1 to 3 lymph nodes that were positive. 5 years ago, if you had even 1 lymph node positive, we were giving you chemotherapy. Now, these tests are so well validated. I mean, they've repeated this research over and over and over again, and it shows to be true every time, that even if you have lymph nodes that are positive and your test comes back low risk, you wouldn't benefit from adding chemotherapy. Now, these patients do need anti-endocrine therapy, so estrogen blockers. But so not everyone needs chemotherapy when they used to. And then in certain more aggressive cancers, like HER2 positive, we know that patients who have small HER2 positive cancers, again, 5 years ago, we were giving you 2 to 3 chemotherapies and a targeted medication. We can now do 1 chemotherapy and 1 targeted medication. So we're reducing side effects, we're reducing toxicities, all by what we call de-escalation. And so we're getting better outcomes, and a lot of times not having to use chemo.
What practices are being done to mitigate the side effects from chemo?
Yeah, that's a great question. The 2 most commonly reported fears that people have going into chemotherapy are hair loss and nausea. We've gotten really good at treating nausea. If you're one of my patients or you've ever seen me, I always tell people at the very beginning, I'm not doing my job if you were throwing up. What you see on TV, people over the toilet, people just sick on chemotherapy, is no longer our reality. We have a full arsenal of medications that we use to help block nausea. So, people really should not be experiencing nausea. In terms of hair loss, there have been a lot of advances made in terms of what we call cryotherapy or scalp freezing. Right now, we can only use it for specific chemotherapies. So we can't always prevent hair loss, but in some situations we can slow it down. And then other side effects that we worry about, neuropathy or numbness and tingling in the fingers and toes from chemo. We can also do cryotherapy, where you wear some super fancy gloves and socks that help freeze the fingers and toes and helps reduce therapy. It helps reduce neuropathy. And I will give a plug for our therapists over at Touro. We have an amazing cancer rehab group who actually helps work with our patients who do get some neuropathy or do get some weakness or muscle issues when they're on chemotherapy. And the cancer rehab group is amazing and really just helps work through a lot of these problems.
Thank you. How would you say, in your own words, chemotherapy for breast cancer treatment has evolved in the last 10 years? I think we kind of touched on this a little bit. Yeah. All right. Are there any other questions in the chat box? It's like a lot of people love you guys.
We love them.
All right, so the next topic is genetic testing, and I'm gonna head back to Dr. Colfry again. Another hot topic in the breast cancer community often surrounds genetic testing and the breast cancer genes. How often is breast cancer gene related, and what patients specifically need testing?
Right. You would think with all the discussion in the media that breast cancer caused by genetic mutations is very common, but it's actually only about 10% of all breast cancers are genetic induced. Like I said earlier, the rest of them are usually from some sort of environmental stimulus that we will never know. With that being said, it's important to know your family history, and there's still a lot of families out there that don't like to talk about this kind of stuff. They don't like sharing that information. They think it's private, and it's important to try to break down some of those barriers and find out that information. Again, the guidelines for genetic testing are sort of a fluid set of guidelines, right? It used to be more of a rigid thing. The NCCN, which stands for National Comprehensive Cancer Network, puts out guidelines on everything, every cancer there is, how to treat it, and also genetic testing for certain cancers. And so for a long time, it was kind of beaten into us the guidelines for genetic testing from the NCCN. So it was specific things like if you were personally diagnosed very young, meaning less than 50, or if you had triple negative cancer, less than 60, or if you had like first degree relatives that had breast cancer, or you had to have like 3 relatives at all, whether they were first, second, or third degree relatives. And so I think, and then recently American Society of Breast Surgeons came out with new guidelines and made it very loose for genetic testing, almost saying that almost anybody with anyone in the family, doesn't matter if it was cousin, mother, aunt, doesn't matter, they're recommending more broad genetic testing almost for all of those people. I think you'll find people across the country kind of following both sets of guidelines. I mean, I think there's still probably a lot of people that do the NCCN, which is probably what we tend to follow a little more in our group, I think. I'm not going to speak for everybody. And so I think it's kind of a case, it's really a case-by-case basis. You know, it's kind of come down to similar to what Melanie was saying about the chemo. It's more of an individualized cancer plan. It's more of like an individualized decision, patient per patient, on who needs genetic testing or not. That was a long, rambling story, but the point of it is basically, if you've got a bunch of people in the family, you need to have some genetic testing. Or if you yourself are diagnosed young, less than 50, you need to have genetic testing done. And anybody else wants to chime in, Melanie or anybody, just please.
If there's a lot of genetics questions, we do have genetics counselors in New Orleans that, you know, are willing to make a pedigree with you and, you know, let you know what your family's risk is.
Yeah, and I know that if you come for a consultation with like myself or with Dr. Colfry or Dr. Zakris, a lot of times we can always just, you know, sketch out a rudimentary pedigree and say, yeah, you know, this looks like something. And, you know, even if you had breast cancer 5-10 years ago, and at that point in time, the guidelines weren't for you to get tested because they have shifted over time, as Dr. Colfry mentioned. You know, there's no need, or there's no reason that you can't have it tested, you know, now. And then as well, if you were tested typically before 2013, you probably only got tested for BRCA1 and BRCA2, BRCA1 and BRCA2 mutations. And so a lot of times these companies will actually rerun your test. If you had a strong family history and, you know, you weren't BRCA1 or BRCA2 negative back in 2008, you know, we can rerun that and see, hey, is there a genetic mutation that we now know? Yeah.
Yeah, Melanie, I think that's a great point. We talked about that in our conference the other day. Tuesday, we have a multidisciplinary breast conference, and we've had a couple of cases where people have come back with a second breast cancer. Their first breast cancer was 15 years ago. Their second breast cancer's popped up. And like Melanie said, either they weren't tested or just they were spot tested for those 2 genes. Now it's like a panel of almost 40 genes. And so it's smart, and we've been rerunning some of these tests, and occasionally we're finding maybe 10, 15% of the time that patient does have a mutation that isn't BRCA1 or 2, you know, that's one of these other all these odd sounding names like CHEK2 or ATM. And so again, it's important to know, if you've had genetic testing, what did you have done? You need, you know, go back and pull the records and look and see.
Yeah, and to piggyback off what you guys said, when we have a lot of patients who come in with questionable family histories of endometrial or uterine cancer or breast cancer, and they want their uterus removed, but are questioning their decision on whether or not to have the ovaries removed as well at the time of hysterectomy, you know, it is worth, you know, sending over genetic consultation or genetic testing to see if there is a family history or some kind of genetic history of, you know, like a BRCA1 or a BRCA2 in the families. And, you know, that'll kind of guide my, my decision on whether or not to remove the ovaries at the time of hysterectomy if there is a positive family history of a breast cancer gene, because ovarian and sometimes uterine and breast cancers go hand in hand.
Mm-hmm.
All right. Someone commented, you mentioned therapy to address neuropathy. Thank you. I've noticed many patients receiving benefit of anodyne therapy. Do the physicians refer to occupational therapy to address the therapeutic wellness, stress management, chemo brain challenges resulting from treatments?
Yes, yes. Again, big plug for not just our cancer rehab group, which is occupational therapists and physical therapists, but also our survivorship team as well. So I typically refer my patients to our cancer rehab group before they start chemotherapy, just to kind of get in and get familiar with what's going on. And then after chemotherapy, we'll often make referrals to our nutritionist, to our counselor, to our survivorship coordinator. You know, you go back to cancer rehab and they'll work through stress management. That's what our counselor can do as well. Sometimes with these chemo brain side effects, you get that loss of words. So sometimes we'll refer to speech therapy, who can sometimes help with that as well. So we definitely at Touro take a full holistic view of the patient whenever they're going through their cancer journey.
Thank you. So the next set of questions, general wellness. So this is going to be for Dr. Green and Dr. Losq-Sarkar. As family medicine and OBGYN physicians, you are often the front line for breast care. Ordering this imaging as well as counseling patients on breast care. Can you discuss the importance of your role in women's health and why establishing a primary physician for annual wellness visits should be a priority?
Sure. So, as an OBGYN, and you know, we see women, well, I try to see people starting at the adolescent age of as young as 13 years old. As an OBGYN, I'm seeing girls who come straight from their pediatrician's office dealing with menstrual irregularities, dealing with birth control and contraception. So, you know, we're kind of the first line as a physician in transitioning into their adult phase of life. So a lot of counseling goes on in those visits. And one of the big things is breast health. When we do talk to those patients, I try to create an environment where the patients are 100% at ease and addressing any concerns or questions that they may have about their bodies in general. So when it comes to breast health, I usually ask an open-ended question. Do you have any problems? Are you feeling any breast pain? And then we get into talking about what it feels like to feel your breast, you know, how to do a clinical breast exam, the difference between a clinical breast exam and a mammogram, because some people don't know the difference between the two. So, you know, we have to be the front line doctors who try to open their eyes into the world of taking care of their body as a whole. So it's very important for them to come to us and address any concerns that they have.
Yeah. Yeah, I agree. I mean, that's a lot of, what we do also in, family medicine, is to kind of get a launching pad to kind of discuss preventative measures in general, in terms of like what it is to, that's kind of based on guidelines for age in terms of like what is considered preventative at that time. And that includes, of course, breast health, and as well as, cardiovascular health and all those things also that you discuss in a kind of in a wellness annual setting. And so, and immunizations and things like that. And I think it's just important to have a time that's dedicated to be able to discuss those things, that sometimes get kind of put on the wayside a little bit because we tend to sometimes get caught up in when you're not feeling well, and so to go when people are feeling sick. But I think it's also very important to have times where in a calm setting you're talking about, preventative measures, and also to be able to have baselines done. So you have a baseline mammogram and it's done every year, and you know what it looked like. And I think that's also important to do. You have like a baseline pelvic exam, and it, and every year you kind of go from that. And so I think that's also the importance of that, is to see how things change and to see if those changes are significant or not. And if you have yearly exams, it's easier to kind of go from there with that. I think, and it's also, I think, important because it allows patients to bring things up that they might not otherwise, or not bring up something one year and then feel comfortable enough to bring it up the next year, along the lines of like family history, for instance. It's something that I might be asking one year. I always ask, but like when I ask, do you have known family history, they may say no, and then down the line, 6 months later or a year later, they can be like, hey, you asked me about my family history last year. Well, it turns out I asked and I do, and so it's, I think, in encouraging those questions, just also kind of brings awareness to patients in general.
So I have a question that came in for Dr. Green. So one of you and Dr. Colfry's patients was pregnant when she had cancer. What do you tell your pregnant patients about breast health?
Oh, so so at their first visit, we tried to do a breast exam, just kind of establishing a baseline of what their breast tissue feels like. Granted, it will feel a little different during pregnancy. They tend to have more tenderness. It's, under the influence of so many hormones. But one of the ways that we can just increase their awareness is just to make them continue doing breast exams and feeling for anything that wasn't there before they were pregnant, or, while they were pregnant in their postpartum phase, because we do have patients who, go through, pregnancy, and then they find out afterwards that, oh, I'm breastfeeding, but I felt this lump. So it is very important to always establish a baseline, and for patients to recognize any changes that may happen. In pregnancy, it's no different from when they're not pregnant. Just establish your baseline and just keep feeling.
I think one of the most important, one of the most serious patients we see is actually when Kristen or one of the other OBGYNs sends me a patient for pregnant patient with a new breast mass. I tell you, when I see that, kind of the hair on the back of my neck stands up, because it can be one of the things that gets easily shrugged aside as just I felt like it was a normal, the patient thinks, I felt like this was just a normal pregnancy breast change. And all of a sudden it's getting bigger and bigger. And I tell you, we've had maybe 5 people this year, roughly, that have had breast cancer during pregnancy. And those cancers tend to be more aggressive. And so I tell you, it's something that when we see it in the clinic, we're all over it. And we see it, and you're either going to get an ultrasound of your breast that day or the next day, and then we're repeating it in 3 months just to make sure that this isn't anything that we need to know about. But you're right, it's hard. The breast is different. It's all, the tissue's different. It feels different. It's hard to tell what's what. But if there's any question, reach out to your gynecologist immediately, because we take it super seriously.
There's a question, what are the statistics of men developing breast cancer? My 21-year-old son has a large breast mass that has grown significantly in the last 6 months. He had a mammogram and ultrasound last year, negative for cancer, but has significantly grown and is very painful. He is told this is cosmetic and insurance would not cover. Should I be concerned? Although cancer was negative, if the mass continues to grow, should it be re-examined? He is young and embarrassed.
Right. Yeah. I mean, I see this a lot too. Men, whether teenage or after puberty, with a new painful breast mass, is very common. It is embarrassing because, you think you're a dude and shouldn't have this kind of stuff, but it's very common. And most young men with these masses, it's benign, something benign called gynecomastia, just extra growth of breast tissue right behind the nipple that's due to, changes, either pubertal changes, hormone changes. Less than 1% of all cancers are male breast cancers. But it's the kind of thing, we see gynecomastia all the time. If it's getting bigger and it's painful and it's changing, somebody needs to check you again and just make sure that it's nothing else going on. Sometimes it does have to be excised. I mean, that's very rare, but if it's growing and getting more and more painful, we do excise it from time to time. But typically, if they're young, it gets better with age. Sometimes in older men, we see it, and it's a medication. Either, it can be a blood pressure medication that can do it. Hair restoration medications can do it. But it sounds like in your situation, I'd have somebody just check it out and make sure everything's okay. Tell them not to be embarrassed. I see it constantly in my clinic.
Yeah. Okay. There was a question, at what age is it recommended for a teenage girl to have an initial pelvic exam?
So a teenage girl, I can't say there's a definite age for them to have their first pelvic exam. There are things that go into play when you're telling a teenage girl to come in to see a gynecologist. So if they are having developmental disorders or menstrual disorders, then absolutely we want to see them to see if we can be of any benefit to them. But if they're not sexually active and aren't complaining of any menstrual disorders, or you're not seeing any developmental delays with your child, then I don't recommend a pelvic exam, because that can be very invasive. And so the goal is to kind of ease your teenager/young woman into their first pelvic exams, because we don't actually recommend pap smear screening for cervical cancer until the age of 21.
The next section of questions are based on the survivorship program options. I'm going to ask Dr. Sheen about it. To wrap up this discussion, I think it's important to highlight the survivors. Breast cancer survivorship is a huge part of the recovery process following breast cancer. What programs are there in place at Touro to help those recovering from breast cancer treatment?
Yeah, so I touched a little bit on our survivorship team. We have counseling services. We have a dedicated nurse who does survivorship with advocacy groups and with support groups, and we even have support groups specifically for young women diagnosed with breast cancer. We have physical therapists, we have occupational therapists with our cancer rehab group. We also have a pelvic floor physical therapist, which is great. And that is definitely something that is often not discussed, but should be discussed a whole lot more, which is after you get diagnosed with breast cancer, you know, if you're on an estrogen blocking medication, you're going to have vaginal dryness. Intercourse is going to be painful, things like that. And your libido may drop. And so having that psychological discussion, physical discussion with your doctor, with your support team is going to be really important. So we've got all these services in place. We also have a nutritionist, because one of the big things about cancer prevention is going to be diet and exercise. Everybody wants that magic bullet that's going to help prevent this cancer from coming back, help reduce that risk of recurrence. That magic bullet is most often going to be leading a healthy lifestyle. If you lead a very active, very healthy lifestyle, your risk of developing breast cancer, your risk of a second breast cancer, and your risk of cancer in general, colon cancer, you know, uterine cancer, ovarian cancer, lung cancer, all of that is going to be reduced with diet and healthy exercise. Same thing with like heart disease and diabetes. You know, all of that is going to be very important for your life going forward. And so a lot of times if people are struggling with that, I will refer my patients to the nutritionist over at Touro as well. And one of her specialties is helping with that. So we've got all of these support services in place that I've talked about. And so really caring for our survivor community is important. And I'd also like to make a little plug for caring for our metastatic patients is very important. A lot of times we think about breast cancer, and breast cancer is a very curable disease for most people, but some people still develop stage 4 metastatic disease. And so caring for those patients isn't just caring for the cancer, it's caring for our patients as well. So, you know, making sure that they're also leading a healthy lifestyle, they're able to have good relationships and not have terrible neuropathy and, you know, not having physical ailments from their chemotherapy. So working with physical therapy. So all of that is really important for survivors and for our metastatic patients.
Thank you. For Dr. Green and Dr. Losq-Sarkar, just a little piggybacking on what Dr. Sheen talked about, the stress, diet, and exercise. Just what conversations do you have with your patients about, you know, making sure that they take better care of their health? One of the most common reasons for not being able to exercise or, you know, eat healthy is because they don't have the time. So what is some type of advice that you would give to your patients and how to make time for that or implement it?
Well, so it's true that it's a little, sometimes it's difficult to make the time. So if you really don't have the time, what I recommend is doing things in little bursts, and to like use what you have available to like be able to exercise, whether it be go up the stairs to go to your office, or you know, park a little further when you go to the store, or things like that. I also kind of try and like bring exercise as well as mental health, and they kind of go hand in hand often. So I think it's also something that's important to kind of prioritize in a way. So if there's stress going on, I think that like often going for a walk is actually good, not just for exercise, but also for mental health. And these days, especially, I think it's very important to be able to do those things. And it doesn't have to be, you know, and that's the other thing is I also say it doesn't have to be an hour a day, every day. It can be small amounts of time, and the goals can be, you know, small. And actually it's probably good to go with more realistic goals, because if we have big goals all of a sudden, then it's going to be disappointing when they're not met. And so it's easier and better and more sustainable to start small. So 20 minutes of walking twice a week, and then kind of go from there. But I do think that kind of seeing exercise is not just good for the body, but also good for the mind. I think kind of is a kind of a 2-in-1 So if you're trying to like, you know, gain time in your day, you can say that your 15-minute walk is not just good for, you know, your maintaining of weight, but also good for maintaining of just your mind. So, so those are some of the things that we go over with my patients.
I agree. And then we also tell patients, you know, if you can, up the stairs, down the stairs, instead of using the elevator, try to do things like that. And also it's important to try to get a buddy to exercise with you. Even if it's just a bike ride or going, you would tend to do things a little bit more, a little bit better if you had someone who was right there by your side and you all are trying to achieve the same goal. So, you know, sometimes it helps to just have that partner with you to motivate you and to getting more active.
I agree.
I agree.
All right. Is there one more question? All right. Right. All right. So I just have one question to wrap up for, you know, each of you. What does it mean for you to get to work with breast cancer patients? To you, what does it mean to you to have the opportunity to work with a breast cancer patient?
Yeah, I'll go first. What we do is it's a sacred thing. I mean, it's very special. And again, it's nothing that any of us take lightly. I mean, our patients, like our family, like Dr. Zakris said, and we get very close, and we don't take those relationships lightly. We're seeing people at sort of their weakest moment, when they're the most vulnerable, the most upset, and there's comfort in that, and I appreciate it every day, and really enjoy helping people navigate through that tough time.
Anybody else?
For me, I have always wanted to work with breast cancer patients since I was in medical school. And there's just a connection that I feel is unique among breast cancer patients. And like Dr. Colfry and Dr. Zakris said, I mean, my patients, I make it a point to, know about my patients. I want to know who the people are supporting you. I want to know your kids' names, because you'll probably know mine. I love to connect with people, and I find that breast cancer patients are very special, and as Dr. Colfry said, very sacred. And we're able to build that connection and really help people through a really dark time and get to that really light time. And it's a really powerful and very special thing that I am lucky and blessed to do every day.
Thank you.
And these patients are very resilient. When I see them either at the time of diagnosis, or sometimes I'll just bump into them, as they're coming back from seeing Dr. Colfry at the hospital. And, they always have the most positive things to say about what they're going through, the physicians, their treatment team. And it's just very humbling to see them so positive in such a situation. The only time that I saw a breast cancer patient all the way through was when she was pregnant. And, to be a part of that team taking care of her, I wouldn't trade it for the world. That was one of the most humbling experiences I ever had in my life, and I wouldn't trade it for anything.
Yeah, I don't see, breast cancer patients like, regularly, but I do sometimes see them, at diagnosis, right at diagnosis. And then I see them generally after their treatments. And my sense is that it's, when I see them when I see my patients who have either, are being followed or are on surveillance, you really have a sense that they are part of a team, that they have a team behind them. And,
Right.
and it's really palpable when you see them. And on diagnosis, when the mammogram, comes up positive, and in the biopsy, and you have to give that diagnosis, and I have a couple times, it's also very good, for me to know that I have a team that I can bring my patients to. And I'm extremely thankful for that. To really know that the resources and the specialists are in place. And not just that, but also a very caring group of specialists that are there for them. So as a primary care doctor, it's really, it's an amazing blessing, really, to have that team that I know that I can send my patients to.
Right.
And I'll just end very quickly by echoing what the others have said. It's an honor, it's a pleasure, and it's a blessing to help take care and participate in the team of physicians and other caregivers taking care of a woman, at her most difficult time in life. And so I'm grateful, love what I do. And love working at Touro with this team of healthcare providers. So,
Thank you. So I want to thank all of our physician panelists tonight. This was very informative. I really appreciate you. Women's health is top of mind in October, yet problems can arise at any day of the year. We want to encourage everyone watching to be proactive in their healthcare and invest in yourself and your well-being. Throughout the month of October, Touro is featuring a different survivor each day who bravely shares her cancer journey. Today, we would like to share with you Dion Haywood's inspirational journey to wellness.
I'm Black. I'm plus size and was a diabetic. All the things that they tell you we are as Black people, we hold, you're overweight, you're this, you're that. And one of the things I dealt with, will they truly see me and will I truly get what I need? My doctors asked a question. How stressful is your job? What do you do, Miss Haywood? Who are you? Do you know how important it is for somebody to ask you who you are when you're experiencing something like cancer? What is your day-to-day? What do you do? And when I told them, they were like, sounds like a very stressful job. And so I said things to my doctors like, thank you for seeing me. And some people may say, well, it's their job to see you. But we know that's not always the case. When I say thank you for seeing me, I mean all of me as a Black woman who is now a 2-time breast cancer survivor.
Wow. Thank you, Dion, for sharing your story. I encourage you all to visit Touro.com/survivor to meet all of our 31 survivors and hear their brave stories of survivorship. Thank you for joining us tonight for our virtual Pampered and Pink at Home. Good night.
night.
Bye.
Good night.
Right.